The DRC's confirmed case count hit 676 today, and underneath that number is a testing system that still can't keep up. This is Ebola Watch. Today we finally have published work to lean on, CDC scenario modeling in MMWR, and a Nature Medicine genomic profile of Uganda's index case.
Which means I get to stop asking, what stops this? And start asking, what the models actually project. The math is on the table now.
It is. Let's start with the update. 41 new confirmed cases, 9 deaths, and where that lands on the CDC's curve.
41 confirmed, 9 deaths in a single reporting period. Sarah, does that day match the optimistic scenario CDC modeled or the pessimistic one?
That's what I want to stress test. The MMWR projections have a fatality assumption, and 9 of 41 is rough math, but it's close to the 17.4% we've been working with, not the historical 30 to 50.
So the 17 holds, at least for now.
For now. I want to know whether CDC baked 17.4 in as the central estimate or as the floor. Because if their worst-case path assumes a higher CFR, the comfortable number is the optimistic one.
And the worst case is the one I'd actually want printed on a traveler's itinerary.
Here's the harder part. Those models assume field conditions. Contact tracing is sitting at 45%. If CDC modeled better coverage than we've actually got, the published curve is already too kind.
The Georgia Public Broadcasting piece says testing improved, but still isn't nearly enough. Has better testing moved that 45% at all, or did it just surface more cases?
That's the throughput problem, and it bites today. If labs are under capacity, some fraction of those 41 confirmed got there slowly, and the suspects behind them are still in line.
Which districts are flying blind? Tell me, in plain geography, not provincial codes.
Fair. GPB puts the shortfall where the case climb is steepest. The labs feeding Ituri and the surrounding health zones are the bottleneck, and that's exactly where the confirmed count keeps jumping.
Now, the Nature Medicine paper, they sequenced Uganda's first patient. What does the genome tell us about how long this strain was quietly circulating?
It gives us the clinical profile and the sequence on one named case. First, it tells us whether the diagnostics being deployed are calibrated to this strain's markers.
And 2?
Second, if that genome links back to a DRC lineage, the cross-border picture gets harder evidence. And then the Kinshasa-Kampala border closure becomes part of the transmission story, a variable you can test against the sequence.
So a closed border doesn't help if the virus already walked through before anyone caught the index case.
If the delayed recognition window is real, that's the implication. The genome is the only thing that can tell us how wide that window was.
And for the regular person who keeps hearing Bundibugyo instead of just Ebola, this is why it matters, right? No vaccine transfers over from the Zaire strain.
Correct. And now we've got a citation for it instead of just an inference. The MMWR models don't include a vaccine scenario because there's no approved tool to model. The response is running on diagnostics, tracing, and isolation.
3 episodes I've been saying there are no doses. Nice to have a peer-reviewed paper agree with me.
Enjoy it. The data caught up to you.
So the honest read for someone tracking this from a couch in the States?
676 confirmed. Transmission ongoing. The modeling treats it as live spread, not lab backfill. The CFR is tracking near 17% for now. The tracing gap is the soft spot. And the genomics will tell us how far this traveled before anyone saw it. From Robert Harriman at Outbreak News Today.
The Ministère de la Santé RDC reported 41 new confirmed cases and 9 deaths, according to their latest update on June 10th. This brings the total to 676 confirmed cases, 629 in Ituri, 44 in North Kivu, 3 in South Kivu. 3 new health zones were affected to include Masareka and Vuhovi in North Kivu, Kambala in Ituri.
The Ministère de la Santé RDC's June 10 update. 41 new confirmed cases, 9 deaths. That brings the confirmed total to 676. And I want to hold on to that word, confirmed. 629 of those are in Ituri, 44 in North Kivu, 3 in South Kivu.
So Ituri is basically the whole outbreak, 629 out of 676. Everything else is a rounding error by comparison.
It's the center of gravity, yes, but the part I'd underline today is 3 new health zones, Masareka and Vuhovi in North Kivu, Kambala in Ituri. New geography on the map is what jumps out, even beyond the case count ticking up.
3 new zones in one update. That's the part that should worry a nervous person more than the 41. The virus is finding ground it wasn't on yesterday.
And there were 2 recoveries in Bunia. Small, but it belongs in the same breath. Surveillance is being stepped up across all affected areas, per the ministry. From Eric Q. Mooring at MMWR.
CDC used the transmission model to project outbreak growth over 3 months by using different assumptions about the number of deaths as of May 24, 2026, and by varying the percentages of persons with BVD who are successfully identified and isolated to prevent ongoing transmission. Assuming 50 cumulative deaths as of May 24, 2026, if 70% of patients were to enter isolation, only approximately 1 in 20 simulations projected an outbreak exceeding 10,000 cases within 3 months.
Okay, the MMWR scenario projections are out. Posted as an early release, June 5th, full report yesterday. This is the CDC actually doing the math on Bundibugyo, and I've been waiting all week to ask one thing. Which scenario is the current count tracking closest to?
It's a transmission model projecting outbreak growth out of Ituri. The thing I want to check is what it assumed for field conditions, because we just heard 41 new confirmed and 9 deaths in a single reporting period. If the model baked in contact tracing at 45% and a 17.4% case fatality rate, then today's numbers wouldn't shock it. If it assumed better tracing than we actually have on the ground, the real curve runs ahead of the optimistic line.
So the model's only as honest as its inputs. The 30 to 50 versus 17% fatality spread we kept circling. Sarah, did CDC pick a number, or did they hedge it into a range?
Nature Medicine with Andrew Sawoteba.
Bundibugyo virus disease, BVD, remains a high-consequence threat in Eastern and Central Africa, where cross-border mobility, nonspecific early symptoms, and delayed recognition can obscure transmission. In this case report, we describe Uganda's 2026 BVD index case, a male patient who traveled from the Democratic Republic of the Congo to Uganda and was admitted to a private hospital in Kampala on 11 May 2026 after more than 2 weeks of vomiting and diarrhea, with epigastric pain, weakness, and hiccups.
Nature Medicine just published the Genomic workup on Uganda's index case, and it gives us something we've been inferring all week. The patient traveled from the DRC, was admitted in Kampala on May 11 after more than 2 weeks of vomiting and diarrhea, and died 3 days later. Bundibugyo confirmed by RT-qPCR after death.
2 weeks of symptoms before anyone caught it. That's the part that stops me cold. He was moving, crossing a border, sick the whole time.
And here's the sequencing detail that matters for the border question. The 2026 genome forms its own lineage, roughly equidistant from the 2007 Butalia and 2012 Iziro variants, about 1.2% divergence. So don't read it as a clean re-import of a known DRC strain. The sequence is distinct.
So the closure between Kinshasa and Kampala, the genome doesn't exactly hand you a tidy, it came from there, arrow.
Not a tidy one, no. But the clinical picture fills in what the diagnostics couldn't catch fast enough. Non-specific early symptoms, then rapid multi-organ failure. That delayed recognition window is exactly where transmission hides.
And it answers the thing I kept circling on Wednesday. Why Bundibugyo isn't just Ebola? Now there's a sequence on the page. The diagnostics being deployed have to be calibrated to these markers, not as Zaire strains.
Right, 99% genome coverage at 100 times depth or higher. That's a usable reference for whether the tests in the field actually match what's circulating. Georgia Public Broadcasting, with Jonathan Lambert.
The problem was that GeneXpert, the machine that forms the backbone of DRC's Ebola surveillance, couldn't detect the rare species that was circulating, says Muyembe. So it was mid-May before officials rang the alarm bell and declared an outbreak of Ebola Bundibugyo. That month-long delay allowed the outbreak to grow into one of the largest Ebola outbreaks ever.
Here's the part I can't get past. The first samples ran on GeneXpert April 30th and came back negative. Negative. Twice. The virus was right there, and the machine literally couldn't see it.
Right, and that's the precise mechanism. GeneXpert is the backbone of DRC surveillance, but it's calibrated to the common species. This Bundibugyo strain slipped through until samples went hundreds of miles to Kinshasa for specialized testing.
So, the genomics matter for a brutally practical reason. If your test isn't tuned to the strain, a positive case reads as negative and you lose weeks.
Weeks they couldn't afford. Officials started worrying in mid-April. Confirmation didn't land until samples reached the right lab. And we just heard the count. 41 new confirmed, 9 deaths in a single reporting period. The throughput gap isn't abstract. Some fraction of those 41 got there slowly, and the suspects behind them are still in line.
And that's why I keep circling the 45% tracing number. GPB says testing has improved. Fine, but improved enough to actually catch the curve, or just enough to reveal more of what was already out there?
Honestly, probably the second. Better detection after 2 weeks of diagnostic blindness can look like a rising case count even when transmission is steady. That's the read you have to hold against the MMWR scenarios.
When I see the alerts say Bundibugyo virus instead of just Ebola, is that a meaningful difference for how officials are actually responding? Vaccines, tests, treatment? Or is it mostly a naming thing?
It matters a lot. Ebola is the umbrella. The specific virus shapes the tests, vaccines, and treatments responders can use. Bundibugyo virus, the one driving this outbreak in the DRC and Uganda, doesn't have an approved vaccine. The shots used successfully in recent Zaire Ebola virus outbreaks, like RVSV-ZBOV, aren't authorized for Bundibugyo. So, per the CDC's Health Alert Network advisory from May 19th, responders don't have a licensed vaccine option right now. Treatments are similar. Monoclonal antibodies like MAB114 and REGN-EB3 were developed specifically against Zaire Ebola virus, so their effectiveness against this strain is uncertain. The Lancet's June 9th commentary noted that, as of June 3rd, the DRC had 344 laboratory-confirmed cases and 60 deaths, while Uganda had reported 15 confirmed cases, and WHO had already declared the outbreak a public health emergency of international concern. The clinical picture matters too. Nature Medicine's case report on Uganda's 2026 index patient describes more than 2 weeks of vomiting, diarrhea, and nonspecific symptoms before he deteriorated fast. That delayed recognition window is part of why the virus crossed the border before anyone flagged it.
So if there's no approved vaccine, what are officials actually doing to protect health workers and contacts on the ground right now?
Then the response leans hard on ring containment. Isolate confirmed cases, trace contacts intensively, and protect health workers with personal protective equipment. Because the vaccine shortcut that helped in previous outbreaks isn't available here. The MMWR field notes published June 11th flagged cross-border movement as a central complication, so contact tracing coordination between Kinshasa and Kampala matters a lot. What I'd watch next is whether any candidate Bundibugyo vaccines in development move toward emergency use authorization, because that decision could change this outbreak's trajectory.
If you've got feedback, a story idea, or a correction for Ebola Watch, we'd like to hear it. Send us a note at ebolawatch@lanternpodcasts.com. You'll find links to all of today's stories in the show notes. If one caught your attention, you can follow it there and read a little deeper. Thanks for listening and take care this weekend. That's Ebola Watch for today. This is a Lantern podcast.